Hello and welcome. My name is Joe Caramelli, and I oversee Grand Rounds for the Department of Psychiatry and Behavioral Sciences. Welcome to today's Grand Rounds presentation. A couple of points about Grand Rounds generally before I talk about today's presenter. I invite you to write any comments or questions into the chat or in the Q&A during the presentation, and I can collect those during the course of the presentation and go through those at the end. There's a group of us that works on Grand Rounds each week, including Mike Walker on technology and Samhara Braha on coordination and communications. We do record and archive almost all the presentations, which you can find on the department website under Grand Rounds. The 2022-23 series is funded through the Ripley Fund and through the Garvey Institute for Brain Health Solutions. Close to the end of the presentation, I'll put a link into the chat that goes to a 4 or 5 question brief survey evaluation about the presentation. That's helpful for me in planning Grand Rounds and in communicating with presenters. Or you can write to me directly anytime about Grand Rounds or ideas for topics or presenters. And now a little bit about today's presenter. For today's Grand Rounds presentation, we've invited Dr. Pamela Montano Arteaga. And Dr. Montano Arteaga is a clinical assistant professor at the New York University Grossman Medical School and directs a clinical service called the Latino Bicultural Clinic at Gouverneur Health and NYC Health and Hospitals. And that's a role that she's been in for about 7 years in that leadership position. Now, this is, like I said, a clinical leadership role that's been consistent with Dr. Montano Arteaga's interests and reflects related scholarly work in this area. For example, Dr. Montano Arteaga worked with the American Psychiatric Association to develop a toolkit for clinicians who were working with undocumented immigrants and fact sheets about COVID-19 for diverse populations. Notably, Dr. Montano Arteaga will continue advancing as a leader and in advocacy through a current and then a subsequent role as president-elect and then president of the American Society of Hispanic Psychiatry. Dr. Montano Arteaga has received several awards for scholarly and advocacy work, including the 2018 Young Physician of the Year Award from the National Hispanic Medical Association and the American Psychiatric Association Award for Excellence in Service and Advocacy in 2021. So with that, I think I'll conclude a brief introduction, turn it over to Dr. Montano Arteaga. Thank you.
Thank you so much, Dr. Caramelli, for the introduction and the invitation. It's an honor to be have this opportunity to talk about our work and lessons learned working with the diverse Latinx population and other immigrant communities. And let me see, I'm going to start sharing my screen. Let's see. So I decided for this very broad title, Latinx Hispanic Mental Health, working in diverse backgrounds and intersecting identities, because I think that has been one of the greater learning experiences that I have had in the past years, not only including my time as a director of Latino Bicultural Clinic and helping to create the clinic and make it grow, but also years prior doing training and other clinical experience in New York City. And it's as other communities, it's a never-ending process. And although they always use this pathogenic term to describe us, Hispanic, Latinx, Latine, we are like a very like multi-ethnic, multiracial population, and with different like socioeconomical and political factors and other identities that are very important when we are trying to provide care to the population, understand ourselves, see the challenges, limitation, our strengths. So that's why I will start with this. I don't have any disclosures. And as I was mentioning before, I just have to always start with this because that will allow me to use any term without feeling that I'm excluding a group, because these terms have been more like used for like American census and in other countries. And like the term Hispanic was like used like in the 1980s, and then the Latino was added like in 1996. And now like we're trying to do more gender affirming care, Latinx, but also there is a lot of controversy about like, oh, Latinx is like, you're kind of using English language into Spanish. So some people are saying Latine, but at the end, like it differs. Like also generations, like my elder patients for certain countries, if I will say like Tines will say, what are you talking about? And also, but my younger patient will say like, no, don't tell me Hispanic because that says like the history of colonization and all kind of stuff. I'm originally from Colombia. Although if you were in this part of New York, people will say, because of the characteristic, the population that more represented, they will say first, I'm from Dominican Republic, unless they start like listening to me in Spanish, but I'm from a coastal town, so it's not that far off. So, but it's very important, like how, and this will be like how the identity, how each person identify themselves as their family, because we are talking about not only like first generation, second, third generation, and that will have an impact about what they have gone through here in US, if they were born here, in their like countries of origin, the acculturation stress and all the other factors. So some of the objectives like increase awareness about the diversity, recognize like major needs and barriers, and providing like Latinx mental health. I will try to discuss some of the models that we have been working in our clinic and also in one of our satellites. And I think like usually this is the most important because this is an ongoing process, and it will be like the need of like interdisciplinary collaboration and community engagement to actually improve the access of this growing population. We have like, for example, like for 2021, the US Hispanic population was already like 62 million. This is like almost 19% of the population. The graph that we have before is a little older, but again, it's also like the countries that have a greater population in US, like Mexico, Puerto Rico, Cuba, and in all this stuff, this will depend on like where we are, like United States. And this is very interesting because as like the population that we serve, that is very, and maybe that's why I'm making like the emphasis in the diversity, is because our population is from everywhere, and different levels of like needs. But it's very important, like wherever you are located, like to know where like your target population, to learn more about it. We need to prevent like doing any generalizations with the population, but it's also useful, like asking people like, where are you from, like exactly, because even in the same country, there are different areas, different political issues that could be driven and could have exposed people to greater likelihood of trauma, and like issues like family separation. And this is like some of the variables that I'm including, like, of course, historical background, like even though the Spanish colonization is is an essential part of like what we consider as Hispanics. There are different histories and also, for example, the impact of U.S. imperialism and other dictatorships that it produces sometimes this like cycle, immigration cycle that involves U.S. Like why some populations come and go, some stay here for generations, some like reunite, etc. Race and ethnicity, colorism, I will talk about that later. Gender identity, sexual orientation, this will go a lot with the cultural values and also the religion, and it will also could increase the vulnerability of several of our patients when they're like double minorities or triple minorities. Language, many areas like although we're talking about Spanish, we have like a Native American population. Certain countries have a greater amount of groups, but sometimes like many people are coming from like South America, Central America, and Spanish is not their first language. And we're taking that for granted. And even if their Spanish is not like even the best to communicate, and getting those interpreters can be very difficult. Geographic location, like pre-migration and post-migration, immigrant status, like this is so important. Because of course that will depend of like job opportunities, certainty is not the same of like someone like even though I came to US and I came like for a work student visa, it's not the same. Like this is a privileged position compared to someone who is coming here as an undocumented immigrant or even an asylum seeker that have to like deal with the system in a different way and the amount of opportunities. And there's of course much different being a permanent resident or a citizen. Educational level will change depending the areas in Latin America and the opportunities and the history and where the people are located, even back home or here, urban or rural, and also like how different they are. And this in many areas. And for any other like also immigrant populations from the host and the representation of that group in the community. So how much they have to assimilate, how is the process of acculturation, all this will be very important. And this is some generalizations, but it's true that in the Latinx, Hispanic culture, of course, there is a lot of like collectivism, although we cannot make that generalization, and sometimes it creates, for example, like a lot of like conflict, especially for like second generation immigrants or third generations, depending like how they see themselves, how's their environment and their parents, and that also can create like issues from like vulnerable spots for mental health, but also también also can be a strength. Especially if you have your family together, but also could be a risk factor when you have your family in very difficult situations back home. You're worrying like about their safety, if they have food, or things that have been, especially during these times, like the COVID wave has affected like so many people in a physical level, but the social impact that has created here in the United States that we have seen it. But back then is significant. And also I think it's one of the important factors also why the increased numbers of immigration encounters in the border, even from populations that they were not as represented as before. Personalism, so this display of mutual respect, trust building, trying to be like they want one-to-one, feeling like closer, so that's like gains trust. Of course, spiritism, that's very important, like to know the line where like the cultural beliefs versus like we are like given the diagnosis of someone being psychotic or something like that. And it's even difficult like because it's a very difficult line, because sometimes it could be, but then the person is not really not doing well, but these already cultural beliefs, they just get like emphasized and like, oh, but it's very good to have in mind, emphasis in the present. So sometimes there could be some resistance, especially when like you are like, they're like, okay, I need to work, I need to like survive. There is no point going back to my past about like all the difficult things that I experienced. But that sometimes like they are like having that in their like in their day-to-day, and it's affecting their functioning and their like actual potential. There is a respect for hierarchy. This changes a little bit. There are like some people from different areas that a little more like, especially for example, like the doctors say like, hey, like, I recommend you this, so they will say yes, yes, I will do it. Doesn't mean that they will do it, but during the encounter, they will like no ask maybe not so many questions or that. So that's why like it's very important like to say like, do you really agree? Like, what do you feel that is the best for you? Like really getting that feedback. While other places, like for example, like I'm comparing like some. And it has to do a lot also with oppression, like population that have been like, especially like Native American, like people from Peru, Mexico, from certain areas, compared to a little bit like people from the Caribbean, maybe they're like sometimes more vocal. I'm talking about New York, but like, so it is different. Of course, there is a patriarchal society. So, and then the colorism, the racism, this is just especially for like female patients is like, I think of course it has to do a lot with the religion, but this idea, of course, we talk about the family, but this endless sacrifice, and that could be many issues because it's just like always like worrying, sometimes like expense of their well-being that goes too far. But it's because like we are supposed to be like spiritually and morally superior to men, and like you have to be the martyr. And of course, it's a generalization, but also this also goes a lot with the issues of like intimate partner violence, also the gender roles, and sometimes this object sexualization of women, seen like less than human, depending in certain areas, and how like so many like crimes and abuses continue to happen. And here, like I was talking about this, so we have a lot of like social determinants that will make a difference, the social support, and all these is impacts in the health and mental health. And then again, one of the reasons, like, because they have a lot of research that tell you the prevalence of mental illness for Hispanic population is 60%, or like, oh, it's lower than the general population. Or when they say, okay, immigrants, first generation immigrants are protected, and then there is the immigrant paradox. However, yes, there could be, of course, because also like to come here, there needs to be a lot of like, it's not easy, especially for many populations, but also it's like when we can divide like where the people are coming from and everything that they went through, the level of education, how the self-efficacy that they can feel here, if they speak English. So these are important factors. And also like when we are talking about like substance use, especially like Puerto Rican population has a higher use of the drugs different than alcohol. And like, why is that? We're talking about like intergenerational trauma, feeling like second-class citizen, even though they're citizens, because that's what in the census, they consider people born in the island, Puerto Rico, as a foreign born, even though they are citizens. So they're also included in that group. And all the consequences of this like adverse childhood experiences and social determinants in the health, like why, of course, there are genetic component to some of them, like obesity, like data, like vulnerability for obesity, but also, of course, the change of like what they used to be their life before and like how is here, the stressors, the budget, eating like healthy food tends to be more expensive than healthy, at least in certain areas, and depends like how expensive are the places where you are living. And all this is very important. And I think I talk a lot about this, but this was like a graph about like the other things. And I think I was using myself as an example, but how important is to take this into account and the political and social context, because since like have been working in the Latino Bicultural Clinic, I think I became the director, and at that time Trump got elected like 2 months after. So like how the population perceive the immigrant population and the non-immigrant population. Because I remember at that time, like there were like 20 of my patients who were citizens, who had green cards, they were like in significant distress in different areas, and also all like how and how also certain like these determinants make a lot of the Latinx population vulnerable during times of COVID in a way that was much higher than other ethnic groups. And this one is just, I just want to mention this because sometimes people don't talk so much about this. And it's about race and colorism. And it's different depending the countries. Of course, like what we consider like Native American population, usually they have the greater disparities in Latin America. And then also the Afro-descendant population. And for some countries, like, that's why like sometimes when I ask, what is your race? It can be confusing, in part because that's no way they consider themselves, and also because they were told no, like to deny certain areas of their background, compared to others where the lemmas have been like more delineating, and there are advantages and disadvantages for both cases and scenarios, because sometimes like the ones that is clear cut, people can advocate, but the one that's subtle and silent, people just don't know. But this graph was, I could like spend like 10 minutes in this graph, but it tells a lot about like the different countries and how like for certain like it could be for example like Panama case, I think is like very interesting how like being like closer to white or even like Afro descendant is better than like Native American, but that also has to be about like the populations that went into Panama and the role that they had and the level of education. And this is just something that I'm going to mention just because immigration, it all depends about, it's different for everyone. It depends on the age, like the depth of how deep was the attachment to your country. The degree of choice is different when you went like, I really like wanted to pursue education or better opportunities, even though sometimes people think that, and then they realize also they don't know how much will be the impact of being far away from their families. But it's not different like being like forced to live or like seen as the only solution. And also we need to take into account that many people like especially undocumented immigrants, they knew the system and they knew the rights, like, and they knew the language. Many of them would have probably classified like for the asylum seeker, but they didn't know because many of them like had terrible experiences in their home countries. and also like how different the place you were like in the rural area, and then like you went to New York City, and yeah, other like. And I think I will talk about the clinic, and then I will go back. But this is very important, like, and also post-migration, because this goes like first, second, like sense of belonging, and that's for everyone. It's very important. So doing approaches that can increase the sense of belonging can really improve mental health, because loneliness can kill us in many ways. And then also, I mentioned this because as a mental health care providers, we need to be very aware about the legal components, and also recognize if we are in front of a victim of domestic violence, a human trafficking victim, because this could serve as like, can save the life of many people or change their well-being completely. If and like being able to do like good evaluations can really make a difference for the population. And this was just like that I found very interesting, because we have heard a lot about like the Venezuelan immigrants in the border and from Colombia. So the Darien is part of, like, even it's close to where I was born. But it's like in general, like people are like fleeing their countries, because especially Ecuador was one of the countries in Latin America that suffered like the impact of COVID pandemic the most. So, and they're going through these long trips that they're like 6 months, 4 months, many people getting killed, like just to where they can see some hope. And there were also like people who were in other countries for like when Haiti had like the earthquake or other like issues. They moved, for example, to Chile, but the COVID pandemic hit, and then they lost their jobs. So they were like, and then it was like why they're coming here after they were in a different country that is not theirs. And then they also, even they could have like the base for asylum before, but usually this, especially now that with the rules, they are like decreasing like the access for many of them. In general, of course, like Latinx population have different, like recently there was an article of like there was a greater percentage of people going to college, but anyway, still there are significant gaps, and in access to care, food insecurity, like the type of jobs. That's why many of them were lost, like they could not have, they didn't have like the benefits, or they were not secure, like when the COVID pandemic hit. At least I'm talking like for New York, but I have been this case in many other places. But okay, I'm going to talk about governor health. So governor health, like, is this clinic, even though the clinic was also actually founded like 1875, and this is like the third location of the clinic. Before it used to be like I think it was the first tuberculosis clinic in the country, but used to have inpatient units. Now it's have the largest ambulatory care center in the New York State. So like just outpatient, and then usually like the higher floors are for administration and for a nursing facility and a rehab. And then mostly of like inpatient care is usually sent to our hospital brother, sister, that is Bellevue. So we are both were like academy affiliates of NYU. And the interesting part, I think I'm going to this, is the location. So we're talking about a place that was founded like in 1875. So it's in the Lower East Side. And so Lower East Side is when you're like have received so many migrants since the earlier times, like from like Jewish, Italians. It's close to Chinatown in Manhattan, like this area. And then the first wave of like Puerto Rican that came to New York, came to this area, and still there are people who have lived there like for decades. And then they will continue moving to different areas in New York City, of course, every time getting more expensive. But then it's very important that we are like next to the F train. The F train is a very important, like, in terms that it goes all the way to Brooklyn, and then it goes all this way to Queens, where we have a large Latino population, and it's very different. So we have like near Gouverneur. So also there are many like NYCHA housing. So we have a lot of like Puerto Rican population from the mainland, or New Yorican, like born in New York, and also Dominican Americans and Dominicans, like they're in the area. And that was initially like, I think, the beginning of the population that they used to serve as a part of the New York City Health and Hospital, that is the public health system for the city of New York. We don't have catchment areas, so we can accept patients from anywhere, from the Bronx, from everywhere. So then, so we have people coming, like not only from like Puerto Rican and Dominican Republic, there's important population in Europe, but then of course the other like will be Mexican population, Ecuadorian, and Central America. And that usually is for issues about like knowledge, health system management. They usually stay more in collaborative care. And that's one of the things like that we're trying to like to improve the access. So, and then you see like, it's interesting because one of the, when I arrived, like one of the things that I liked was that everything was translated to Spanish and Chinese. So it was very interesting. And then we have in the clinic, because of the history, there is a large LGBT population. And then it has a lot of hipsters too, and other people from different areas. And because this is a public clinic that people like with insurance and no insurance can come. If you don't have insurance, we have a pharmacy on site that I know that's a luxury compared to other places, that I can like send medications to my patients without having to worry about like high costs, because it will be like depending like in their income. And also we have a lot of other like population, but the most will be like Latinx population and Asian. And that's why like even like the Asian Bicultural Clinic, that's also very known, was founded in 1984, and it was serving Chinatown. And then the Latino Bicultural Clinic like had the population, but it was more like meetings, but there was no like a clear like organization for the group, or like how to do an assessment, like how to improve the care. So we started with different initiatives, like doing like providers, like cultural assessment for patients, what they wanted, what were areas that we needed to improve. And also we have a very diverse team. We have like, of course, we're supposed to have more people, but I don't know how it's in the case in Seattle, but providers of mental health, more if they're bilingual, they're moving, especially of COVID, because COVID was a pretty tough time for all of us. So, but we have been able to like retain a lot compared to other places. And it's still, so we have like 3 or 4 psychiatrists, a nurse practitioner who was a family medicine practitioner for 10 years. And then he decided to be to be in psychiatry. We have NYU residents, PGY3 or PGY4, doing the outpatient rotations. Social work interns from different universities, psychology externs. We also have here like a program that right now is not moving that much, but it's supposed to be of collaborative care via telehealth to serve other areas, one in Brooklyn and one in the Bronx, because now we are part of this bigger system called Gotham that have been a lot of changes. And then we have groups. Some groups have been like long-term, ongoing, and other had been like pilot projects or short-term groups that we wanted to see like how the population responded. Of course, as I say, like we have a very diverse population. So for example, like for our elderly population, like groups in the mornings are easier. But for example, for our like first generation immigrant population that works, usually like late evenings are like better times. And also it's difficult because also there are people who are working many hours, and let me tell me, like I should mention something about the COVID pandemic here, but like there are some groups that that we are back in person, but there are others that were affected and had to be done like on the phone and then later on video. But of course, like there were different levels of like still like, until now, like how easy it's for them, the access or the issue with technology for the elderly population. I have learned that it's easier for them to get the link via text than email. But then like adolescents, younger population is easier, but also like many people, especially after like so many, because for example, in the times of let me, oh, I cannot move this. Let's see. Okay, 1 second. Okay. In the time of the COVID pandemic, the impact also like, because especially, it was especially the population that was nearby, and then it was later the one that would live in the other counties, like when they were telling us like 2 brothers die, or like so many family members, or they got sick, and it was very traumatic for them. People were writing will like papers like, oh, if I die, who should I leave, my daughter or son? And people who were already like with significant trauma. So exacerbated, and also for like all the neurological impact that COVID also can have. But yeah, the food insecurity, like something that, for example, that that we found helpful with the system was, for example, that as many people lost their job, there was a program. It was only like $1,000, but at least was something that if someone was apparently like got COVID and they lost their job, they could apply. They were like a patient of our facility. Sometimes people like got sick and never noticed COVID, so we're just ordering antibodies before the vaccine to see if like they could like get at least a help. But like essential workers, that many of our patients were affected, of course, the agricultural industry, and that part of like there were families like living in rooms and like rent that they could not afford, and like and that were very difficult times because people were getting affected in the social, economic, daily life, but also they were losing family members. And then when like the peak of New York, like the beginning, like when it got better, but in Latin America was, or is still, people continue dying from COVID. So still we had patients who were like, my dad and my mom died from COVID like 6 months ago. So, and also as mental health providers, like the impact that had in us, like was very important to do groups, processing groups, because we also had people that we lost or that we were uncertain about it, and it were like a very tough time, and like the consequences, I think, continue and will continue reflecting of our acute burnout on the top of the chronic one, because also the minority task responsibility, like there were so many stuff that we were doing, but like the level of severity that the population had, and also like even now, like we have many services, and but the need is so much, so many community clinics close, and so there are waiting lists. and has to prioritize depending on the needs, and collaborative care and integrated care that we have for OBGYN, for pediatrics and medicine. That works well, although we lost like 2 psychiatrists. So it worked well when we had the people and also social workers, because it will help also like for the stigma and other things like to patients to engage to care. And then because something very common, especially with the Latinx population, is that people say, oh, estoy ansioso, tengo nervios, nervous, but many times, yes, they're anxious, nervous, but that could be the peaks of the iceberg. It could be a way of expressing, because it's more acceptable, that they are like depressed, they feel lonely, or it's just like typical of like complex trauma. So or even like it could be like a hypomanic symptom. So it's very important, because they always say like, oh, Latinx population is very emotional, they talk, but no necessarily always they're talking about the actual feelings. And that's why also like sometimes like especially when you're like victim of trauma, the somatic expression, and that there has to be a fine line, because anxious people also get coronary artery disease and an infarct. So sometimes they are like, people are not taking attention if this person have like, oh, they are not just anxious. So it's a fine line. And but there were many people that I have the panel of a patient that, yeah, like they were dismissed during the COVID times because they were so busy. And unfortunately, the person died. Let me see. Okay. I wanted to also to mention, so another thing that for us has been very important has been working with the community health workers. So we do now part of like social determinants screening. That's very important, because we need the needs. Doesn't mean that we have all the resources to connect them. And we're doing a better job now after we lost a lot of like those connections, and now we're trying to get in touch with the community organization, because especially for our clinic, I don't know if I explain it well, but because it's not only the catchment area around the Lower East Side, but a lot of our population, it comes from like some areas of Brooklyn and Queens. So it's like we have to reach out to those like senior centers or community centers that are in the other. And that's like one of the reasons, like not only for the clinic, but in general, has been like trying to, that we should get more united and at least the resources, because there is a lot of like, even in New York, I don't know all the services that there are in New York. It's sometimes people, we are working in silos. People don't know, even my own system, like this is a clinic, this is our satellite, and it's part of the Guvernor, and also I have some administration in, related to this. And this is a community center that was founded in 1983, and they focus mostly in family work, and especially for the Puerto Rican population in this village and also Lower East Side. And they have one of the, I think the last standing adult day treatment in Spanish in New York City, at least. And their roots, like their connections with the population, is stronger with the surrounding, but they're mostly like I would say 50% or 60% are like speak English, and they also have other like people from the community. So it's interesting because I do a lot of like asylum UVs evaluation, and here I was doing a lot of NCIS 48 forms that are for like naturalization after like the COVID, like because so many stuff were like not working during the COVID times. So people were like trying to do the process to become citizens, well, to improve the voice of the population. But it's important, like even with the same system, part of the goal has been like, how can we work together. Like they have things, and I was like, they are supposed to have 3 psychiatrists, and I was supposed to cover for 1 month, and then that covering for 6 months. Something that a psychiatrist does, like 3 psychiatrists do, plus my usual job. So it has been just ended. We were able to hire people, but it was just a very good opportunity to see how things work and how like it could increase the communication, because division, like, and I know because they had a history of like, there was a time that the city was trying to close the center. So there are a lot of differences, and that's sometimes like it's frustrating that we need to be united. Like we are a diverse group, but the only way that we can think about like everyone, of course there are experts in different fields, is that we work, because then we will be this like major group with a voice. And this, like I was mentioning, like there is a need of more research, but like research like with these components of like, because the experience also of the population in Utah, other places can be different, and also the different groups. And I was talking about like, for example, like substance use disorder and opioid dose, usually it's more like Puerto Ricans than others. And then when we are like analyzing a data, like see like it's including all of them. And even though after adjusting like different variables, like what is the actual outcome. And intimate partner violence still is higher levels than before. Of course, the peak was more during COVID times. We always had like 1 in 3 Latinas experiencing intimate partner violence, but of course, more people like stuck at home was a greater issue. And stigma is still like a major barrier. However, because things got so bad, and it will depend on the region and the level of education and the media and all of that. So probably it may be different in like Washington State, but we have seen a significant decrease. Or not a decrease, or maybe people are like, even with, despite the stigma, they're like requesting services because the need is so great, especially for child and adolescents. And usually it's also like trying to like, we are not enough, like in psychiatry, in behavioral health in general, and less bilingual. So how we collaborate with others, given like cultural sensitive care, and also we use or collaborate the population and empower them to help us in other areas, in the church, in the school, in the other areas where like we can like prevent or have a greater impact, and also like and work with our other like colleagues, and because this is not going away, and it just like the level of distress and all this like younger population that didn't go to school during the COVID pandemic, and all the repercussion, and like so many people that don't want to return to school, and they already were having like identity issues, acculturation, like being in the 2 worlds, and this all like just exacerbated everything. And the medications, like people think you get to take medications because you're really local. So there is part to like really pay attention to this part, and also explain like depending on the case, and that it will be a process, or like I really recommend that you will have long-term, you have certain like genetic vulnerability. But also like there has been a lot of misdiagnosis, like for example in the day treatment program that is for SMI in Roberto Clemente. It was the same experience that I had when I work. I was doing a evaluation, cultural evaluation in a state facility in New York. Many people like being diagnosed as schizoaffective, when they actually have NDD with psychosis in the past, bipolar, or have other issues. So, and that, yeah, like that there was no recovery models. That's something like that we are working very close, like, so with the vocational housing. That's easier. The more difficult, since that we need to get better, is like vocational for other, like the ones that have more limitations due to immigration status. Let me see something like how, because wow, I need to leave some time for questions. So I'm just going to, I think, probably summarize with this. As many things like there's sometimes this distrust of authority and power, because they don't know how will they receive, or the experiences that they have, or their parents. So community engagement, and community engagement. Going there, like, I know that we need to move, like it's easier in some places than other, but being there, like being the community, doing like some stuff that we do a lot is community events, of course, because of the pandemic, and people are like crying for it. We try to do some digital ones, of course, didn't like well, everyone could participate, but before it was education and also some entertainment, of course, because we need music, we need all the stuff, but that's not belonging, that you were not alone, or like, oh, I'm from this area, or also process groups that you feel identified, you're not alone. And that part of like the narrative, because that can empower us. And also like integration of services. We have immigration lawyers on site. That was like 1 year after I arrived. In the year before, I was doing like panel, like try to inform people. People were like, when they arrived, for me was like, they make my life much better, being able to refer to like get learn about it, like and they were for one time they were in the same floor, the behavioral health, then they went to the third floor. But like that part of like, if you have these services, or like financial or vocational, like close by, it makes much easier to people to navigate. Not everyone has the resources or knowledge to navigate our complicated system. And yeah, and like focuses on the social determinants. And yeah, and all this, we need advocate in different areas: education, research, fundraising support, community research. And I'm a little, yeah, I think thank you so much. And if you have any questions, I just wanted to like already.
Well, thank you, Dr. Montano Ortega. We do have a couple of minutes for any participants to write in questions. Very informative. Here we've understood about the services available, rationale for it, how it's staffed, bicultural considerations, a series of questions. I encourage others to write in questions. One of the first I wrote down, I wasn't aware about residents and maybe other trainees working in this clinical site. I wonder what addition, beyond clinical skills, consultation, clinical decision-making, are there other objectives that you might comment on that trainees come away with?
I think like for many of them, the community experience, being a community insight, especially for being in the hospitals in New York, that's a very new experience for them. And many sometimes they have come like with like public health interest. So they're going like, they want to see the service, they want to see like ideas of projects, like how can we implement different services, adaptations, and also like just increase, how can I say, when they, I remember like, but that was not just a first year medical student, that she wanted to be a psychiatrist. That was, she was thinking, and she was like, can I take it? Like, how do you do it? It's so much. She had a bad day. The patients that I was seeing, that they have like very complex trauma. They were very like, I was like, oh no. And like, I need to give her like different types, but it was because she was sensitive. But it's just this awareness of like, the issues that there are, but also the hope. So I think like that's one, in addition to the clinical, like how to work with the population, be curious, like open-minded, and know, like, because we all have biases, and also how to see a community that like is so diverse also, because we have the Latino Bicultural Clinic, but then you have like surrounding, and also they're like, and they live together, and also they also know everything is like roses, right? Like sometimes a group is like against the other, and how to mediate, and the importance of, or sometimes they are participating like in some of our projects, like prescribing vegetables, or like the cooking classes, or stuff like that. I think that part of like that you can do more than the clinical, and also you could do, if you do changes in a systemic level, maybe you will be able to have a greater impact, especially for the site residents that look like to come to our clinic, and they do like part of the outpatient rotation instead of the Bellevue. And the 4th year is also an elective. And then we have, I forgot, medical students for their 4th year. And also I'm working in the global elective that we work also with places in Ecuador for Spanish people, like students that want to learn Spanish medically.
I'm probably smiling because it's a lot of, I guess as director, a lot of things come to you.
Yeah.
But as you were replying to that question, a question came in regarding stigma, navigating stigma regarding psychiatric illness. We're working with patients or family members. Is there a useful approach, examples of questions or ways of directing a meeting that kind of helps with this?
Yes. The behavioral health service, or the primary care, or before?
Let's say within you're seeing someone directly, let's say.
Yes. Yeah. So I think like usually like first we cannot take for granted that someone came from our service because they felt okay coming. Sometimes they just like listen to the recommendation of the primary care doctor, or they even have an idea, like they thought, oh, I'm going to do talk therapy, but then they saw me, right? And they, oh, the psychiatrist medications. So it's just like explaining like also the same thing, like emotional distress, many things has happened. We are just trying to help you to cope, and there are different methods, like different approaches for every person depending on their needs. But like this is more normal, like being like completely okay and not having like emotional distress is like more rare, especially when you're coming from this background of so much deprivation, so many stuff. So, and people who are very resilient. So, but it's a process. It's like, for example, like I know, like unless the patient is very severe, like I will probably, if I can wait, even I think like they need medication, like probably 2 weeks after I will give the appointment. Well, like they are like trying to get to know me, like feel like, oh, I'm doing the blood work. It's like a step by step. And also, for example, like and also like normalizing that I don't know, I think like if people feel the connection, that you're listening to them, right? That you are not imagine, like thing that they imagine. Also, they see the community, right? Like that is the same than the other places. And that at the end, what we are trying is to help them to feel better, to achieve their potential, to be less stuck, or like, I think like they feel that. So it's usually like listening a lot, why they think, like asking them, what do you think? What are your like concerns? Like being active in that part. And then I'm trying to work with them, because it's teamwork. It's no one telling like other what to do, but yeah, always ask questions. And like, if you see some hesitancy, like go for it. And that will pay off later on. That is one of the recommendations.
Yeah, it's helpful guidance with maybe changing the pace of intervention at times, or building trust, being curious, asking questions, focusing on the relationship. And I think interestingly, you commented on patients meeting with others within the clinic. Maybe that in itself helps to diminish stigma.
Yeah. And sometimes there is also stigma within our own mental health professionals, like about medications, like with like therapists or stuff like that. So working with team, learning about this, like for example, like I'm a psychiatrist. Initially they were like, oh, they thought like you're the director and you're like, oh, but you probably will think like you're focused on medication, but I actually love psychotherapy and social issues. So actually I like more that. So like learning as a part of respect, or like, okay, that we are like seeing patients in a holistic way and working together. And then everyone as a team communicating that to the patient, that has a greater impact. And also we are very diverse in our approaches. So that's also helpful. Yeah.
Well, Dr. Montano Ortega, here we are just a minute or two after 1 o'clock, and we're at the end of our grand rounds time. I want to thank you again. Thank you for presenting during our grand round series. I appreciate it a lot. And I think we'll have to end there for today and leave it at that. But thank you again.
Thank you so much. Someone asked about like the slides.
Oh,
I didn't send them yet, but I will send them so people can have them. Yeah.
Oh, that's great.
Mm-hmm.
Thank you.
Thank you. Thank you so much. And I hope it was useful. And I forgot to like my last slides to be my email. So anyone can contact me, but I probably will send it with the slides. So you can have it. Feel free to contact me if you have any questions or want me to focus in specific areas. Thank you so much.
Very good. Well, take care. Bye.